Welcome to the deep dive. Today, we're really diving into something crucial: HIV antiretroviral therapy, or ART. If you're a clinician, maybe just stepping into an HIV clinic, or honestly, even if you've been practicing a while, this deep dive is, well, it's designed for you. Before we really get started, just take a quick moment. Think about one thing you're truly grateful for today. Could be personal, could be professional. For me, it's just having this platform to share these really essential conversations. And speaking of that, a massive thank you to all our subscribers. Your support genuinely helps us reach more clinicians and, ultimately more patients. So thank you.
Yeah, and that sets up our mission perfectly for today. We're aiming to give you a practical clinical guide to ART. The goal here is to blend, the deep clinical knowledge with those real-world patient scenarios. So you feel confident choosing therapy, starting it, adjusting it when needed. We'll be focusing on first-line treatments, some alternatives, the newer long-acting agents, switching strategies, and something really key, optimizing adherence.
Okay, let's start right at the foundation. The current guidelines seem pretty clear. RT is recommended for everyone with HIV. It's not just about the individual patient's health, right? It's bigger than that.
Exactly. It's a powerful public health tool, too. The main goal, clinically speaking, is durable suppression of plasma HIV RNA. Think of the HIV RNA level as, well, the amount of active virus in the blood. Get that down, keep it down, and you stop the disease progressing, prevent drug resistance from developing. Plus, it preserves or even improves CD4 T cell counts, which means huge clinical benefits. And this is central to the U idea, undetectable equals untransmittable. If someone's viral load is below 200 copies per ml, they can't transmit HIV sexually. That's massive.
So when someone's starting RT today, what's considered the gold standard? What are we reaching for first?
For most people, the go-to choices are oral second-generation integrase strand transfer inhibitors, NSTIs, combined with two NRTIs, nucleoside reverse transcriptase inhibitors. The big idea is combining high effectiveness with ease of use. These regimens suppress the virus really well, they're generally well-tolerated, have good safety profiles, and importantly, they often come in single tablets, taken just once a day. That makes sticking to the plan, adherence, much easier for patients.
Right. Let's break down some specific top choices then. First one: Biktarvy, emtricitabine, tenofovir, alafenamide. That's BICETFFTC, brand name Biktarvy. Why is this such a strong recommendation?
Okay, Biktarvy. It's listed as an AI recommendation, the highest level for most people starting out. The advantages are pretty clear. Bictegravir itself has a really high barrier to resistance. It means the virus finds it very difficult to mutate around it. Plus, no food requirements, which is convenient, and minimal interactions through that CYP3A4 pathway in the liver. That's a big plus. Fewer worries about clashes with other meds. And the TFF part, the tenofovir alafenamide, it has fewer bone and kidney side effects compared to the older version, TDF. And FTC, emtricitabine, that's just a really solid, widely used NRTI backbone component.
Okay, sounds very good. Any important things to keep in mind with Biktarvy? Caveats?
Yeah, a couple of things. Both bictegravir and another NSTI dolutegravir can affect how the kidneys handle creatinine. They decrease its secretion in the kidney tubules. So what happens is you might see a small bump in the serum creatinine level on lab tests, maybe zero point 0.1 to zero point 0.2 milligdl higher. But, and this is key, it doesn't reflect actual damage to the kidney's filtering function, the glomerulus. It's more of a lab finding. The other thing is weight gain. We have seen some association between NSTIs and weight gain, and that's definitely something to discuss with patients.
Okay, good to know. Next one: dolutegravir bictegravir lamivudine, DTJABC3TC. Trimec. There's a really critical screening step needed here, isn't there?
Oh, absolutely vital. Before you even think about starting any regimen containing abacavir, you must test for HLA-B5701. It's a genetic marker. If that test comes back positive, the patient absolutely cannot receive abacavir, ever. The risk of potentially life-threatening hypersensitivity reaction, or HSR, is just too high. It's a hard stop.
Right, that's non-negotiable then. Assuming the screening is negative, what are the upsides of Trimec?
Well, dolutegravir, like bictegravir, also has that high resistance barrier, no food requirement, minimal CYP3A4 interactions. It also tends to have a favorable effect on lipids. The ABC3TC part, abacavir, is co-formulated, and importantly, generic versions are available, which can help with cost. And abacavir itself doesn't cause kidney problems, which can be an advantage in certain patients.
And any downsides or considerations apart from that crucial HLA screening?
There's been some debate. Some studies have shown a possible link between abacavir and heart attacks, myocardial infarction, particularly in patients who already have cardiac risk factors. It's not universally agreed upon in all studies, but it's definitely something to weigh up, especially if your patient has known heart issues or multiple risk factors.
Okay. And the third main option you mentioned was dolutegravir, DTG, combined with either TAF-FTC or the older TDF-FTC. What guides the choice between those two backbones?
So DTG again gives you that high barrier to resistance. Both TF-FTC and TDF-FTC are effective NRTI partners. The main difference is TF-FTC generally has fewer bone density and kidney issues compared to TDF-FTC. On the other hand, TDF might be associated with slightly lower lipid levels. The big caution with TDFs is for patients who already have kidney disease or osteopenia or osteoporosis. You need to be careful or avoid it, and definitely monitor kidney function, urine glucose, urine protein closely if you do use it.
Okay, so just to quickly recap these first-line options for someone listening, what's the main takeaway?
I'd say these NSTI-based regimens are really the workhorses now. They give great viral suppression, they're generally easy to tolerate, and they're designed with adherence in mind, once daily, often single pills. The choice between them often boils down to individual patient factors: kidney health, bone health, potential drug interactions, cardiovascular risk, cost, and of course resistance testing results.
Let's make this practical. We have a case scenario. Imagine a patient newly diagnosed with HIV. Their CD4 count is 380 cells per cubic millimeter. No hepatitis B co-infection. And their kidney function, eGFR, is good at 80 ml/min. How would you approach starting RT here?
Okay, for this patient profile, Biktarvy, that's BICTFFTC, looks like an excellent choice. Why? Well, it's an AI-recommended first-line regimen, like we said. Their eGFR of 80 is perfectly fine for TNF. Remember, TNF is gentler on the kidneys than TDF. Even with good baseline function, it's preferable. The fact they don't have hepatitis B simplifies things a bit, although Biktarvy is active against Hep B because of the TAF and FTC. And crucially, it's a single-tablet regimen. For someone newly diagnosed, that simplicity is a huge boost for adherence right from the start.
Yeah, that sounds like a pretty straightforward choice in this case. What about the lab work? What absolutely needs to be done before starting Biktarvy, and what monitoring is needed after they start?
Right, before starting, you need your baseline labs. That means HIV RNA, the viral load, and the CD4 count. You absolutely need HIV drug resistance testing, genotypic testing for the reverse transcriptase and protease genes. And consider testing the integrase gene, too, if you suspect NASTI resistance, though that's less common up front. Also, a complete blood count, CBC, checks on kidney function, creatinine, eGFR, and liver function, AST, ALT, and comprehensive hepatitis B and C screening. For Hep B, that's HBsAg, anti-HBs, and anti-HBC total. That tells you if they have active infection, immunity, or past exposure, and HCV antibody or RNA for Hep C. And even though we chose Biktarvy here, best practice is to always get that HLA-B5701 test on file at baseline, just in case you ever need to consider ivacavir down the road.
Got it. Comprehensive baseline. And then after they're on the medication.
You need to check that it's working. So repeat the HIV RNA, the viral load, usually between 4 and 8 weeks after starting. You want to see that number dropping significantly. CD4 counts need monitoring too, but the frequency depends. Initially, if the CD4 was low, say under 300, you might check every 3 months for the first couple of years. If it was higher, maybe every 6 months. If they stay suppressed for 2 years with a CD4 count consistently above 500, guidelines say further CD4 monitoring might even be optional. And you'll want to keep an eye on kidney and liver function periodically, maybe every 6 months or annually, depending on the regimen and the patient.
Okay, that makes sense. But what about when those preferred first-line regimens like Biktarvy or Triumeq just aren't the right fit for a particular patient? When do we need to think about alternatives?
Yeah, this is where tailoring therapy really comes in. A huge factor is drug interactions, or DDIs. For example, some anti-seizure drugs, or even the supplement St. John's wort, can interfere with Biktarvy because of those enzyme pathways, CYP3A4 and UGT1A1. Boosted protease inhibitors, like darunavir boosted with ritonavir or cobizistat, have a lot of potential interactions. These like certain antiarrhythmics, some sedatives, even some statins. Even the NSTIs we like so much, things like calcium or iron supplements or antacids with magnesium or aluminum, can block their absorption if taken too close together. You have to space them out, often by several hours.
So checking every single medication, including over-the-counters and supplements, is absolutely critical.
Yeah, negotiable, yeah.
What about other patient factors, comorbidities?
Definitely. Kidney or liver problems are big ones. Like we touched on, TDF is usually avoided if kidney function, CRCL, is below 60 milliman. TAF is the preferred tenofovir option then. Some boosted PIs also have restrictions based on kidney function, especially if used with TDF. And severe liver disease can limit the use of certain PIs too. For cardiovascular risk, remember that debated link between abacavir and MI. It's a discussion point. And some drugs, like rilpivirine, need caution if the patient is at risk for a heart rhythm issue called QTc prolongation. Neuropsychiatric illness is another area. The older drug efavirenz had significant issues, sleep problems, vivid dreams, depression, even psychosis sometimes. Newer drugs like rilpivirine and doravirine can sometimes cause depression or sleep issues too, but generally less often than efavirenz.
And pregnancy comes up often.
Always. Perform a pregnancy test for anyone with childbearing potential before starting or changing RT. Regimens containing cobicistat as the booster, that's the C in things like Convoy or Prescobex, are generally not recommended for starting during pregnancy. Drug levels can drop in the later trimesters, risking loss of viral suppression. Interestingly, efavirenz, which had early animal data concerns, has not shown increased birth defect risk in humans. But always check the specific perinatal HIV guidelines for the latest recommendations.
Cost and access are real-world barriers too, right?
Huge barriers, out-of-pocket costs can absolutely torpedo adherence. The good news is we have excellent generic options now, generic ABC3TC, generic TDF-FTC, even a generic combination with the dovavirine. These can make a massive difference. Programs like ADP, the AIDS Drug Assistance Program, and other foundations can also help patients afford their medications. And while single-tablet regimens, STRs, are super convenient, we don't have definitive proof they're always better than taking the same drugs as separate pills once a day, a multi-tablet regimen or MTR. So especially if a generic MTR saves a lot of money, it's a conversation to have with the patient. Shared decision-making is key.
Okay, so based on all that, can you summarize specific drugs clinicians should actively avoid in certain situations?
Sure. Let's highlight the big ones. Efavirenz, EFE. Generally avoid if someone has significant pre-existing psychiatric illness or is at high risk for those CNS side effects. Apigaluria, ABC. This is absolute. Never ever use if the patient is HLA-VP 5701 positive, and never try it again if you even suspect a hypersensitivity reaction. Rilpivirine, RPV. Not the best choice to start therapy if the baseline viral load is high, over 100,000 copies ml, or if the CD4 count is low, under 200. It's just not as potent in those situations and has a lower barrier to resistance. Also, watch the QTc interval. Cobicistat, use in regimens. Generally avoid initiating in pregnancy and be careful with low kidney function if paired with TDF. Tenofovir sparing regimens like DTG, 3TC, Dovato. This is a 2-drug regimen. It shouldn't be used if the person also has hepatitis B unless you add another drug specifically for hep B, like entecavir. Also not recommended if the starting HIV viral load is very high, over 500,000, or if you don't have resistance test results back yet.
That's really helpful clarification. Now let's shift gears to switching our case. Someone's already on a regimen, it's working okay, but maybe not perfectly. Why would we consider changing it?
There are several good reasons. One is simply simplification, maybe moving from multiple pills to a single tablet, or reducing dosing frequency, or getting rid of food restrictions. Another is to improve adherence. If a regimen has annoying side effects that make it hard to take consistently, switching might help. Or maybe fitting it better into their lifestyle. Managing side effects is a big one, switching from TDF to TF to reduce kidney or bone impact. Switching away from efavirenz if CNS side effects are bothersome. Addressing weight gain, though in STIs themselves can cause it. Or managing lipid changes. And optimizing drug interactions. If a patient develops a new condition requiring medication that clashes with their current RT, like needing complex treatment after an organ transplant, switching to a regimen with fewer interactions, like an unboosted NSTI, becomes really important.
Okay, let's talk specifically about a newer option. The long-acting injectable, biktarvy plus rilpivirine, LACABRPV, or Cabenuva. This is quite different. Who is this for?
Right, Cabenuva is approved to replace an existing oral RT regimen. The key criteria are: the person must already be virologically suppressed on their oral meds, meaning undetectable viral load, and they must have no history of treatment failure and no known resistance to either bictegravir, which is an NSTI, or rilpivirine, an RTI. It's really important to understand it's not for starting therapy in someone who's RT naive. We don't have the data for that. It's purely for maintaining suppression in people already doing well on pills.
Makes sense. So for eligible patients, what are the practical things a clinic needs to consider?
Well, the biggest is the injection schedule. It's given as 2 intramuscular injections, 1 of each drug, usually in the glutes. Initially, it was monthly, but now there's an every 2-month dosing option available after the first few doses. Regular clinic visits for these shots are obviously essential. You can't miss them. There's an optional oral lead-in period where the patient takes bictegravir and rilpivirine pills for about a month first. This is mainly to check tolerability before committing to the long-acting shots. But it's not strictly required anymore. It's a discussion between provider and patient. Handling missed doses can be tricky. The major studies that showed success especially in patients who sometimes struggled with pills, often included a lot of extra support. Intensive case management, reminders, transport help, financial incentives, even home injections sometimes. This tells us that just offering the shot isn't enough if adherence is the main underlying issue. Without that kind of wraparound support, managing missed doses and maintaining suppression could be challenging. And generally, it's not recommended for people who currently have a detectable viral load, especially due to adherence issues. The studies were done in suppressed patients. While some small observational studies suggest it might work for some struggling with pills, those cases usually involve that very intensive support system.
That intensive support aspect is really interesting, and it leads nicely into our next topic, optimizing adherence overall. Because even the best drugs don't work if they aren't taken.
Absolutely fundamental. And a key principle here is that things like ongoing substance use, for instance, are not reasons to withhold RT. People using substances can absolutely achieve and maintain viral suppression. Our job as clinicians is to build a trusting, collaborative, non-judgmental relationship with the patient.
So what are some concrete strategies we can use in the clinic to help maximize adherence?
Several things. We already mentioned single tablet regimens, STRs. When they're clinically appropriate and affordable, their simplicity is generally preferred. Thinking about incorporating patient lifestyle factors is crucial. Ideally, regimens should be simple, once daily is best, have a high barrier to resistance in case a dose is occasionally missed, and low risk of liver toxicity. We also need to talk about things like pregnancy intentions, but we have to go broader too. We need to actively address stigma, which is still a huge barrier. Mental health issues, substance use, these can profoundly impact someone's ability to engage in care and stick with treatment. This means tackling social determinants of health, things like unstable housing, lack of transportation, poor insurance coverage. These aren't separate issues. They directly affect adherence. Managing side effects promptly is critical. Side effects are a major reason people stop taking their meds or switch regimens. Table 21 in the DHS guidelines is a great resource for listing common side effects and potential alternative drugs. And finally, a multidisciplinary team approach is often the most effective. Having nurses, social workers, case managers, pharmacists, peer navigators all working together, providing compassionate, person-centered care. Things like active linkage to care services, appointment reminders, help with transport, maybe even financial incentives. These have all been shown to improve retention and adherence. And tools like telehealth and mobile health apps can play a role too.
Okay, let's quickly circle back to monitoring and follow-up for patients on stable RRT. What are the essentials?
You need to keep track. HIV RNA viral load is your main marker of treatment success. Check it periodically, maybe every 3-6 months, once stable. If it becomes detectable and stays above 200 copy/ml, that's virologic failure, and you need to do resistance testing right away. CD4 count tells you about immune recovery. As we said, frequency depends on their counts and duration of suppression. It becomes less critical once someone is stably suppressed with good counts. And renal and hepatic function monitoring continues, frequency depending on the specific drugs they're on and any underlying conditions. Always be proactive about side effect management. Ask about them at every visit. Investigate thoroughly because sometimes other conditions or medications can mimic ART side effects. If something severe happens, you might need to temporarily stop or switch the RRT. And I'll say it again, resistance testing is vital. At baseline to guide initial choices and absolutely crucial if treatment starts failing to guide the next regimen. Genotypic testing is usually preferred initially.
Perfect. So after this really comprehensive deep dive, what are the absolute key takeaways you want our listeners, those clinicians in the HIV clinic, to remember?
Okay, 4 main things. 1, first-line regimen selection. NSTI-based regimens with 2 NRTIs are the standard, yes. But the choice is always individualized. You have to weigh efficacy, side effects, pill burden, dosing, drug interactions, resistance results, cost, access, and patient comorbidities like Hep B, kidney liver issues, pregnancy status, heart risks.
Got it. Individualized. What about Biktarvy specifically?
2, when and why Biktarvy is a great choice. It's a powerful, convenient, single-tablet, once-daily option. Ideal for many treatment-naive folks with good kidney function, no major drug interactions looming, and no known pre-existing resistance. High efficacy, high resistance barrier.
Practical tips for switching and injectables.
3, switching and long-acting RT. When switching, the goal is always to maintain viral suppression while improving something else: simplicity, tolerability, interactions. For long-acting injectables, Cabenuva, remember it's for maintaining suppression in already suppressed patients who can commit to the injection schedule. It's not for starting RT in naive patients.
And the 4th point.
4, adherence and patient-centered care. Adherence is complex. It's tied up with social determinants, mental health, substance use, stigma. Our approach has to be holistic. Patient education, shared decision-making, using the whole support team, addressing barriers without judgment. And remember, ongoing substance use doesn't mean someone can't succeed on RT. Our role is support.
That's incredibly valuable. As we wrap up, here's something for you, our listener, to reflect on. What's one strategy you can perhaps try or emphasize tomorrow to help improve RT adherence in your own patients? Just mull that over. And again, a sincere thank you for subscribing and supporting the deep dive. Your engagement really does help get this information out there.
Yes, thank you. And please, if you found this helpful, share it with your colleagues. Spreading best practices, sharing knowledge, that's how we strengthen HIV care for everyone.
And one final thought to leave you with. Considering how rapidly RT is evolving and how unique each patient's journey is, how can we as clinicians continue to adapt? How can we ensure our care is truly patient-centered, going beyond just the prescription pad to support sustained well-being and a long, healthy future for every single person living with HIV?